All right, we are live. Good morning, good morning. How is everybody? Good? Good. Not too bad? I know the weather's getting really cold. I don't like it. I live in Florida for a reason. All right, you guys had 2 chapters over the weekend, chapters 5 and 6. 5 was on dementia, and 6 was a skills chapter. Does anybody have any questions? Anybody have any questions? Yes. It was 5, right? Yep, chapter 5. Let me pull out my book here.
I would think the first part of it was on answer C.
Okay.
B, yeah, but not the second part.
Okay, so number 2 is, if a dementia patient is hallucinating, you should, so what is the right answer here? A, correct them immediately. That doesn't work, actually. They will argue with you because a hallucination can be very, very real. And if somebody is hallucinating and you tell them, no, there are no children in the room, to them, yes, there is. And that can start off a very adversarial relationship. So correcting them, not a good idea. Tell them they're hallucinating. Well, that can often create some anxiety. You know, if I told you you're hallucinating, well, now their anxiety can go up, and anxiety, if you're hallucinating, can actually make the hallucinations worse. So telling somebody they're hallucinating, probably not the best idea. Redirect the patient or ignore the hallucination. That's actually your best bet here. Get them involved in an activity. Get their mind on something else. Take them for a walk. Talk about something, current events, or something going on at the facility or something like that. You just want to get their attention off of the hallucinations. That's the really big thing here. We don't really play into hallucinations. We don't try to deny them. We just redirect. Does that make sense? And then call the doctor because the medications aren't working. That's not our role. Whose role is that? The nurse. So D would not be correct. Does that help?
Yeah, I thought it was C, but I wasn't sure about ignoring.
Yeah, the ignoring the hallucination, that just means that we're not playing into it. We're just not going to address it. And this happened to my grandmother, actually. She had congestive heart failure. And when she sat up for long periods, her heart was very, very weak. And it couldn't really pump good blood up to her brain. So her brain, without good blood flow, sometimes would hallucinate. And she would hear kids playing outside. Well, there were no children playing outside. But trying to tell her, no, there's no kids outside. That's, in her mind, yes, I can hear them. Yes, they're real. So that, that wouldn't work. So we just tended to ignore them. Now, ignoring them doesn't mean that we're just leaving them in a room to deal with their own hallucinations by themselves. It just means that we're not really going to talk about it. We're going to redirect them. So I usually would pick up a book and read to her, or turn on the TV, or get her involved in a puzzle, or in most cases with her, because I knew it was lack of oxygen to the brain, I would get her to lay down for a few minutes. And when she laid down, of course, now we're not fighting gravity to get blood to the brain, and that would usually take care of the situation. So let's lay down and put your legs up for a few minutes. Sometimes I'd have to lay on her bed with her and put my legs up for a few minutes just to get her to kind of play along. Sometimes we do some, sometimes to help our patients, we kind of have to do things that we wouldn't really think of doing. I wouldn't lay down in a stranger's bed, right? That would be inappropriate. But for my grandma, yeah, I'll lay down next to her and put my feet up to get her to cooperate. In a clinical setting, if it were a stranger, I'm not going to lay down on a stranger's bed to make that happen, but I might get the patient to lay down and say, I'll read to you if you lay down and just close your eyes for a few minutes. Let's get your legs up so we don't get swelling. Something like that. So you kind of have to adjust your approach to each patient. Make sense? Any other questions on chapter 5? No other questions? All right. Yes.
I kind of got confused between the words pacing, delusions, and wandering.
Okay. So pacing is back and forth in one area. Pacing. It's just, it's pretty obvious that somebody has some anxiety when they're pacing. Wandering is something different. Wandering is just not really going back and forth in one area. Wandering is just kind of wandering. I wander through stores all the time. No real direction, no real destination. I just want to see what's on the shelves, right? Just wandering. Now, wandering can lead to elopement, which is exit seeking. Somebody that's in a locked unit gets out without anybody knowing about it. That's called elopement. And that's a real danger. Because think about it for a second. If you have dementia and you're in a locked unit, that's where you live, but that's not in your mind. That's not your home. You think of home as your home, where you live now. So if somebody were to put you in a locked unit and say, this is where you live, your body is saying, this is not where I live. I want to go home. So you'll start looking for a way out. And any unsecured door, any exit, staff exits, sometimes, they'll go through the kitchen because they're just wandering and they'll find an exit out through the back kitchen door. So we have to be really, really careful and understand what's driving that. And it's not that they're trying to give us a hard time. They want to go home. They don't understand that this is now their home. They can't really accept that. So pacing is back and forth, kind of agitated pacing. Wandering is just going in all different areas without any real destination. Elopement is exiting a facility. And what was the other one you were asking about? Delusions. So those are all physical actions. So pacing, this is pacing, right? This is pacing.
What we commonly do when we're on the phone.
Yeah, we pace a lot on the phone. Absolutely. So this is pacing. Wandering is more just kind of no real destination. And elopement is leaving a facility. Those are all physical actions. Motion. Delusion is not a physical action. It's mental, psychological, but it's actually more perception. So a delusion is a strongly held belief that isn't true. So if I told you that I was the reincarnated Queen of Egypt, and I acted like the reincarnated Queen of Egypt, and I dressed like, and I told everybody, that's a delusion. It's not true. I am not the not that I know of, the reincarnated Queen of Egypt, right? It's not true, but it's something that influences the way I interact with the world around me. It is a strongly held belief that's not true, but it affects my interactions with others. Good? Does that make sense? So pacing, wandering, elopement, those are all physical actions. Delusion is a psychological fixation. Now, delusions are a little different than hallucinations. Those two get mixed up a lot. A delusion is a belief. A hallucination is a sense. So I saw something, I heard something, I smelled something, I feel something, right? Your five senses. hallucination has to do with those senses. So if they see children, if they hear children, if they feel spiders crawling on them, if they smell burning in the building, those are all hallucinations. Now, hallucinations can be very scary, but they can also be very benign. Did you see the little doggy? Did you see that? That's not a scary hallucination. They can be very benign. You never really know what you're going to get with a hallucination. Good? Make sense? Our goal is to try to get their mind on something else, and those hallucinations go away. Delusions, not so much. A delusion will usually stay, even if we're redirecting somebody, it tends to stay. We have to do much more intensive therapy and medications and things like that. All right. Questions on that? Let me go ahead and get your scores. This is going to be for chapter 5 and 6. Just tell me how many you missed. Paula. Olivia.
1 on each.
Thank you. Cindy. Thank you. Gabriella C. Melissa. Ariana.
For chapter 4, I got a 15 out of 20.
Okay.
And then for chapter 5, I got 100. And then for chapter 6, I missed 2. So I think it's a 90.
90. Very good. Fabrice.
90, 95.
Thank you. Brianna D.
190.
Thank you. Antonio. Thank you. Gabrielle H. Daniel. Thank you. Drew. Brianna R. Amara. Mahala. Thank you. All right. Any questions? No? Any questions on what we've covered so far in class? Is anybody lost? Cheers. Class is half over. So if you've not registered for the test yet, you probably should. That whole process from the time that you register until you're testing is about 3 to 4 weeks. So you don't want to wait and then, register, because the longer you wait to register, the further it's going to be for you to test, and the more likely you are to lose confidence because you'll forget some of the things that I've said. Remember that you have these class sessions to review. You can go online and watch all of these classes again if you have to delay for any reason in testing. Good? Good. You also have the online course. You have your book. You have a lot of resources, but the best option, guys, is to register for the test and take it. You are prepared. I know you don't feel like it, but you are prepared for the test. You really, really are. So don't delay feeling like, well, I'll wait until I graduate, or I'll wait until I get a little more practice, or I'll wait for whatever. You want to, good morning. You want to test as soon as possible. Okay.
You said something about the CPR thing?
Yes. So the CPR is going to be the Monday after graduation. I'm waiting on Julie to give me the QR code. She's actually having a special page on her website made just for our students. So you guys will get a QR code to be able to register for CPR.
You said the Monday after graduation?
It'll be the Monday after graduation, and it'll be here in this room. But I don't have that QR code to be able to register yet. And that's just to give you guys a special price that she's not offering to anybody else. So hopefully I'm going to be able to meet with her today. I'm hoping she comes in today And if she does, I'll get her to get with her website guy to give us that code. So I have the game show tomorrow. This is probably going to be relevant to you guys now because you're almost done with the class. We only have 3 classes after today. And the game show goes over 15 test questions and reviews the right answer, but I also explain why the right answer is the right answer. So it's a learning opportunity as well, but you're competing for real prizes. The game show, the first place winner gets a t-shirt, a 4YourCNA t-shirt. Second place winner gets the card game. Third place winner gets some motivational items. So you're competing for real prizes, but it's a way of practicing for the questions that you're going to see on the state exam. And tomorrow is all about infection control. So 15 questions on infection control. And I show you where in the test plan that, all states have to create their test according to a test plan made by the NNAAP. A lot of letters there. So I actually show that test plan and how I create the questions, how I get the categories. So you can kind of see a back end look how a test is created. So that might be helpful for you. But that will be tomorrow at 11 a.m. on our YouTube channel. So how do we know what to do with each patient? The care plan. We follow the care plan, the whole care plan, and nothing but the care plan. While we're doing that, we should be observing for anything, any abnormalities. If it looks funny, if it smells funny, if it feels funny, if it sounds funny, we need to report it. And who are we reporting it to? The nurse. Very good. Every skill starts with the opening. Every opening starts with a knock. Once we enter the room, we're going to address and how do we do that? By name. What do they need to know about us? Yeah, what our name and title is. And then we're going to describe the skill we're going to do. Why do we have to describe the skill? We have to get permission. Very good. Once we get permission, we can close the curtain, and that curtain is not clean. So what do we want to do? Wash our hands, and then we can go get our clean supplies. Our cardinal rule here is do not touch the patient until your hands are clean. Sometimes we're going to have to use gloves, but we have to learn when to use them and when they're not necessary. So we're going to use gloves if we're going to encounter one of 3 things. So what are the 3 things that require us to use gloves? Body fluids. Okay, so skin openings, yep, non-intact skin, and bathing suits. Yeah, private skin, personal skin, anything normally covered by a bathing suit. So if we decide we need gloves, because one of those, we're either going to touch body fluids or personal skin or non-intact skin. If we do need gloves, what's the first thing those gloves should touch? The patient. This is the really big deal about gloves. You've got to keep them clean for the patient. But then once you've worn gloves and now they're soiled, you've got to pay attention to what else you're touching to prevent cross-contamination. And then we have to learn how to remove our gloves correctly. Skin can touch skin. Skin cannot touch dirty glove. So we go underneath to remove the glove. I'm sorry. We pinch up to remove the glove, and then we go underneath to remove the second. Good? Questions? A barrier is used anytime we use supplies. So lots and lots of skills require the barrier. It's all about clean. Barriers are all about clean. A barrier provides a clean place to put your clean supplies. And we only touch our supplies with clean hands. You don't want the supplies to touch your uniform. And we always get the barrier first before we go get the rest of our supplies. That way we're not holding those supplies against us as we're spreading out that barrier. Sometimes we need a privacy blanket. How do I know when to use a privacy blanket? Yeah, no knobby knees. Absolutely, no knobby knees. If the patient's going to be uncovered or undressed, we need a privacy blanket. And it's not just there for privacy. What else is it there for? Yeah, to keep them warm, keep them comfortable. Sure, absolutely. Don't get so caught up in your experience that you forget to think about what the patient is experiencing. And it's cold in facilities. It's very cold. If you take that sheet away, it's going to feel very uncomfortable for our patient. Now, should we just take the sheet completely away and then put the blanket on? How do we do this then? Okay, so put the blanket on first. How do we put the blanket on? Do we snap it? No. We just lay it, unfold it, and lay it over, and then pull that sheet down underneath. Good? And then at the end of the skill, we're going to remove the blanket after we remove our gloves. You don't want to touch that sheet with soiled gloves. Starting to see how these principles are all kind of clicking together? Good. All right, so we had linen rules as well, and most of these are repeats, right? Linens can't touch your uniform. Good morning. What kind of hands do you need to get linens? Clean hands. And what can't you do with linens when we're spreading them out? Yeah, snap them or shake them, throw them. Sure, absolutely. So those are all repeats. We've learned all of that. But we also learned that clean rolls toward, and dirty rolls away. And that's how we're going to change linens if we have to have that crossover point between clean and dirty. Clean rolls toward me, dirty rolls away. Good? All right, don't let any linens touch the floor. It doesn't matter whether it's clean or dirty, doesn't matter. And anything you take into the room but don't use, can you leave it in the room for later? No, anything that's out of our sight cannot be considered clean. Good? Good. All right, we don't need side rails to keep our patients safe. Just don't need them. Your patient is safe if they're in the, where in the bed? In the middle of the bed, in the center of the bed. So we don't have side rails in all settings to keep our patients safe. We have to do that. So if we have to turn a patient over, they've got to be in the middle of the bed after the turn. So that means we scoot them toward us and then we turn them. Do we turn them toward us or away from us? Always away. But our cardinal rule here is the patient must always be in the middle of the bed. Always. Washing rules. We have a lot of washing skills that we do. We're going to learn how to do one today as well. The longest skill we have, partial bed bath, we're going to go over today. And in order to wash, we have to think about how that happens. So whatever we wash, we rinse. Yeah. And whatever we rinse, we dry. That's right. That means that we need clean water for rinsing. So can I put soap in the basin? No. So basins are no soap zones. When we get water for bathing, remember, all we've touched is clean stuff. So when I go over to the sink to get water, what do I need to turn that faucet on? A paper towel. How do I know the water temperature is okay? Check it with your wrist. How should it feel? Just warm. Not hot, not cold, just warm. And who else needs to check it? The patient. Guys, the evaluator will probably put their finger in that water. So for the test, you got to treat this like it's a real patient situation. Don't fill it up with cold water and pretend. You've got to use warm water because the evaluator will probably check it. We're going to get to the leaves method today. Don't worry about that too much yet. Whatever we wash, we rinse. Whatever we rinse, we dry. And try not to get your surface wet. If you're cleaning a patient and they're in bed and you accidentally get the sheets wet, should you ignore that for the test? Yeah, can you leave a patient in a wet bed? No, absolutely not. So just try real hard to protect your surface. If you're working on a table, we're going to use a barrier for hand care. If you're working on the floor, we're going to use a barrier for foot care. If we're doing any other washing skills and we're cleaning with the patient on the bed, we're going to put something under the area we're cleaning to make sure that we don't get those sheets wet. Good? Make sense? All right. And then if we apply lotion, what do we have to do before we put the lotion on? And what do we do after we put the lotion on? Wipe off the excess. Basin cleaning. This is really easy. Dump it, rinse it, dry it, store it. That's it. That's all we're doing for the test. But when you store it, remember, you haven't washed your hands yet. When you put that basin away, should you touch that drawer with dirty hands or dirty gloves? What are we going to use? Paper towel. Very good. And then the closing is done at the end of every skill. You have to end the skill with clean hands and a patient that feels cared about as well as cared for. So to do this, we're going to make sure they're in what kind of an environment? Clean environment. Right. The bed height has to be in the lowest position. Yeah. We have to ask them a question. What's our question? Are you comfortable? They need to hear that word. Very good. As part of comfort, we're not just concerned about physical comfort, we're concerned about emotional as well. So we're going to offer them a magazine. Very good. You can also adjust the head of the bed if they request it. We don't have to ask for the test, but if they request it, address it. Once we get all of that done, we also have to make sure that the patient is covered. Remember, no knobby knees. So if they're laying in bed and all they have on is a patient gown, they need their sheet on. If we've dressed them, they're covered. They're dressed. Okay. Once we get all that done, we're going to open the privacy curtain, give them their call light. All of that stuff, there's a whole lot of steps there. There's a lot of steps there. All of that stuff, the order doesn't matter. Nobody cares. Comfort, curtain, call light, clean, or clean, call light, curtain, comfort. Nobody cares. Just get them all done. Once you get all of that done, though, then you have to go clean your hands. Now, when you're at the sink and you're washing your hands and you realize, oh my gosh, I didn't give them the call light. When you go back to give the patient a call light, what are you encountering? What are you? Yeah, right. Patient cooties. So what do we have to do? Wash our hands. Don't ignore the fact that they don't have a call light. Go back and give them the call light, but you need to understand that that environment is unclean. Even though you just washed your hands, that environment is unclean. So the very last thing that you have to do is wash your hands before you document. Not every skill requires documentation. In fact, there's only 4 that do. Pulse, respirations, feeding, and emptying the urinary drainage bag. Now, we've already covered 2. We're going to get to the other 2 as we go. Good? If you get one of those 4 skills, and you will, because everybody gets a documentation skill. If you get one of those 4 skills, you're going to wash your hands, you're going to document, and then what do you need to do after documenting? Wash your hands again, because you have to end skill with clean hands. Good? Easy, right? Okay. I'm going to go through the rest of these really quickly. So when we're taking a pulse, we're going to use the radial pulse located at the top of the patient's wrist. Their arm needs to be supported, not hanging off the bed, not stranded in midair. We don't use our thumb to take a pulse. Normal is between 60 and 100. You do have to count with both evaluators, and you do have to document for this skill. Good? Use your fingertips, not the flat part. They're much more sensitive. It's easier to get. But during the test, if you lose the count, remember we have to count for 1 full minute. If you lose the count, it's okay. You can start again. You can start as many times as you need to. But who should we be telling? Who? The patient. That's right. Because if you count and then you go, oh, I messed up. Let me start over. And you're talking to the evaluator, that patient feels like they're a byproduct of this. They're not involved. We have to get our patients involved. So I wouldn't talk to the evaluator. I would tell the patient, I'm so sorry, I lost count. I'm going to restart. Again, take me about a minute. When you direct all of your conversation to the patient, it shows that you care about the patient, not the test. Make sense? Good. All right. We also learned how to dress a resident. And the way we remember this is USA first, undress strong arm first. But there's a couple things with this one. We want to minimize exposure. So we're going to get the clothes before we undress the patient. We're going to make sure that there's a privacy blanket on to protect them from us. We're going to make sure the privacy curtain is closed to protect them from everybody out there. Patient gets to choose their own clothing. And you want to be careful when you're putting it on not to overextend or force movement. But at the end, the patient needs to look good. Their pants need to be over their hips. The toe seams need to be across the toes. The shirt needs to be buttoned appropriately. They've got to look good, guys. That's the whole thing. They've got to look good. We always lift from below. Anytime we lift an extremity for any skill, we lift from below, supporting at the joints. And at the end of the skill, you don't have to cover the patient because they're dressed, but we can ask, do you want the sheet on? Good. Call light should always go in the stronger hand. Why? Yeah, they may not be able to use it with the weak hand. Absolutely. Absolutely. Hand and nail care. We're going to wash one hand, rinse one hand, dry one hand, lotion one hand, clean under the nails, and file the rough edges. That's it. That's the whole skill. It's a mini mani. That's all it is. But when we're doing this, all of our washing rules apply. And this skill is all about judging whether you know those washing rules. So they're grading you on getting the water and checking the temperature and asking the patient to check the temperature. They're grading you on all of that. That's a big part of this particular skill. So we're going to support the arm and hand at all times. When we have the hand out of the basin and on the table, we're not just going to throw it on the table. We're going to lay it on the towel so there's a softer surface. When we clean under the nails, we're going to use a slanted end of the orange stick as a scoop, circle it around, and then wipe it off in between. And when we file the nails, we always file in one direction toward the center. Lotion is always going to be last. We'll warm it up. We'll put it on. We'll wipe off that lotion. And then we're just going to clean all of our environment up. You know, that's actually, I know that seems like a no-brainer to you. It really does. But that's actually a very common mistake on the state exam, is that students will get done with the skill. They'll put lotion on. And then they'll turn around and tell the evaluator, okay, I'm done. And there's still a basin on the table. There's still soiled linens on the table. They didn't open the curtain. They didn't give the patient the call light. They didn't go wash their hands. They didn't do anything as far as cleanup. They focus on the steps of the skill. This is not the skill. This is a part of the skill. Does that make sense? That's a huge problem on the state exam. Students do this all the time. They just, okay, I'm done. And the job isn't done until the environment is clean. Very good. Very good. Making an occupied bed. We're just going to change the bottom sheet a half at a time. Remember, if the bed is empty, make it while it's empty. Way easier. But if we have to make an occupied bed, we're going to make it a half at a time. So this is where that clean rolls toward me, dirty rolls away, comes into play. So we're going to get our patients laying on their side in the middle of the bed, roll the dirty sheet toward them, tuck it, roll the clean sheet towards you, and tuck that under the dirty. Go to the other side of the bed, take the dirty sheet away, and unroll the clean. Don't let the patient lay on a bare mattress. That's icky, right? Don't let the patient lay on a bare mattress. We want to minimize any wrinkles, and then we'll make hospital corners, which means getting the corners off the floor. No corner, nothing should ever touch the floor except feet. We'll loosen the sheet over their toes and replace the pillowcase with the opening facing away from the door. Side lying position. We scoot the patient toward us, and then we prep them for turning. Furthest arm up, closest arm over. Closest knee bent, furthest knee angled. And when you do that, you simply roll them on their side. It is super easy with no stress on you or them. If you don't position them properly first, you will be struggling with this. It's all about proper positioning. Once you get them on their side, we're going to put a pillow behind their back, pillow between the legs, pillow under that top arm, and we'll adjust the pillow under the head to make sure it's not under that bottom shoulder. Call light goes in the bottom hand. Good? Questions? Foot care, just like hand and nail care, a little lower. We put the foot in the basin. We take it out to wash it. We put it back into rinse. We take it out to dry. A lot of students ask, well, what if we have to do both feet? Do I do them both at the same time? Sure, you can if their feet fit in the basin. They got little feet, that's fine. But if you got some size 15 gunboats, you're not going to be able to fit them both in the basin at once. So you would do them one at a time. Good. Even though we're cleaning, right? We're washing, we're rinsing, we're drying, we're lotioning. Is that really why we're doing this? Why are we doing this? To look. That's right. So during the test, you have to say something like, I'm looking at the foot. But you can also talk to the patient, which is what I would recommend. Mr. Jones, I don't see any abnormalities. Your skin looks good. I'm not seeing any red areas. Do you have any sore spots I need to take a look at? Something like that. If you address all of your communication to the patient, those evaluators are pretty smart cookies. They'll keep up. Good. At the end, we're going to replace that sock and shoe, whatever they wore in, because you guys don't take clean socks with you to the testing center. But in a clinical setting, you would give them clean socks for their clean feet. And make sure that that shoe is secured appropriately. I'm going to tell you a little cheat for this or hint for the test. When you go in and get checked in for the test, they look at these evaluators are RNs. They assess as well as they breathe. Okay. So they look at your body size because they're going to try to pair you up with somebody your body size or smaller if you're going to have to move a patient, like ambulate or transfer or sideline position. Good? Makes sense? But for foot care, they also look at your shoes. So as you come in, they're going to kind of give you a once over and take a look at you. And you have slip-on shoes. So do you. I can't see yours over there. But you have shoes that don't tie. So you guys would be great patients for foot care because by the time we get to the end of this skill, they don't want to watch you tie somebody's shoes. They just want you to get the shoe on and let's move on. Because where do those evaluators want to be? At home in their pools. That's right. So if you wear slip-on shoes that don't tie, you have a higher likelihood of being a patient for foot care. Good. But if you're the one performing foot care, you want somebody with slip-on shoes because it makes it so much easier. Good? Questions? Mouth care. Don't overthink this, guys. It's mouth care. What position does the patient need to be in? Sitting straight up. That's right. We're going to protect their clothing with a towel. You wet the toothbrush before you put toothpaste on it, and then you brush whatever they got. Nobody cares how. Just make sure you get the top and the bottom and the front and the back and the tongue. After you do all that, though, you need to let them rinse as much as they want to, as much as they need to. And when they rinse, you're going to give them something to spit into, like an emesis basin. When they spit into the emesis basin and they're all done, we're going to dry their mouth off. Don't forget that step. That is the number one step that people miss on this skill. They forget to dry the patient off, and the patient's just sitting there dripping. How uncomfortable is that? Then we'll go clean our basin and put our stuff away. That's it. Super easy. Respirations. We don't want to tell the patient we're counting their breathing because that alters their breathing. But we're going to count for as long as the care plan tells us to. For the test, that's 1 full minute. Normal is between 12 and 20. Between 12 and 20. And remember, in and out counts as one whole cycle. So you're not going to stare at the clock. You want to stare at the patient and glance at the clock every so often. Good. Questions? This is a documenting skill. So you have to document at the end. We also learned some range of motion. Range of motion is done by CNAs to retain function, which means we're just trying to keep what they've already got. Not trying to make anything better. There's 3 exercises CNAs can do. There's up, down, which is flexion, extension. There's abduction, adduction, which is side to side. And there's rotation, which is around. How do we know which exercises we have to do? The care plan. How do we know what body part? And how do we know how many repetitions to do? Yeah, as long as you follow that recipe, guys, this is the easiest skill to do. The easiest. Questions? So look how far you guys have come. I want you to think about that. Class is half over. And look how much you've learned. That's crazy. So let's go ahead and learn another range of motion today. Another range of motion. This one is range of motion, hip, knee, and ankle. Now, we just went through this. We know this. We're going to follow the care plan, and it's going to tell us what exercises, what body part, and how many repetitions. But if you look on page 80 here, it reviewed what we just talked about. I have a video for this. And down here is test-specific information. So this is going to be done on a real testing student. That could be you. And you're going to be laying in bed as a patient for this skill. Somebody with your level of experience should be able to do this in 4 minutes or less. Super quick. Now, range of motion of the hip, knee, and ankle is a little bit different than range of motion of the elbow and wrist. Did we do elbow and wrist or did we do shoulder? We did elbow and wrist. It's a little bit different. And the reason is the hip and the knee is a 2-for-1 exercise. So one exercise, we get 2 joints out of it. And I'm going to explain to you why. This is actually really important, especially when we're working with older individuals. So if you look at the top of page 81, you can see our care plan there. It says, provide the following range of motion exercise to the resident's right hip, knee, and ankle. Flexion, extension. So we only have one exercise to do here. That's it. Flexion, extension. And we have to exercise the hip, knee, and ankle. It also tells us to do 3 repetitions. So hip, knee, and ankle. Step-by-step instructions are here. If you follow them, you'll do the skill exactly right. But the hip is actually a 2-for-1 exercise. So when your patient is laying down and you bend the knee up to the chest and then back down to the bed, so up to the chest and back down to the bed, it bends both the hip and the knee at the same time. So we're getting 2 joints with one exercise. What you can't do, especially with older individuals, what you want to avoid is a straight leg raise like this. Don't exercise the hip by bringing the leg up and keeping that knee straight, the reason for this is not good. You have to be a physical therapist to do this, or a certified trainer, because you've got nerves. You guys remember the nervous system we talked about? You got the brain and the spinal cord, and then the nerves come off of that. You guys remember that? Well, there's two main nerves that serve your legs. So at the bottom of your spinal cord here, it breaks off into two main nerves. This is called your sciatic nerve. Now, it happens to run right through your butt muscle. And as we age, remember I said we get less bendy? You guys remember that? We get less. It's not just your muscles that get less bendy. Your nerves actually get less bendy too. They tend to calcify, get harder. So this is pretty straight already. It's pretty tight already. And when you try to lift that leg up, that's going to pull this nerve super tight. So think of like a rubber band. If I stretch that rubber band, this is a nerve though. If we stretch that nerve, it's going to aggravate it. And your patient can end up with sciatic pain for days or weeks after doing a straight leg raise. So it's really important that we not do this, that we bend the knee at the same time. Now the test knows this. So during the test, if you do this, a straight leg raise, not bending that knee, the evaluators will mark it as the wrong action. Does that make sense? Do you guys understand why? Because it's going to have a longer term effect on your patient. This isn't an immediate ow. Like your patient, isn't going to, like, if they had a sore bicep and we got to here and they said ow, well, that ow isn't going to stay with them. Sciatic pain will stay with them. And very, very, very common as we age, that sciatic nerve inflammation. All right, so let me go back here. So the hip and knee are going to be done together, 3 repetitions. We're just going to bend the knee to the chest and back to the bed 3 times, supporting from under at the joints. And then we're going to do the ankle separately. But with the ankle, we don't want that heel to scrape against the sheets as we're bending that ankle forward and back. So we want to make sure that we lift that leg off of the bed just a little bit, not straight leg raise. We're just trying to get that heel off the bed as we bend the foot forward and then back gently toward the head. And you'll feel a little stretch in there. You'll feel a little stretch in there. Good? So here's our care plan. We provide the following range of motion exercise to the resident's right hip, knee, and ankle. Pay attention during the test. It may say right. It could also say left. So you need to pay attention to what your care plan says for the test. We're going to do flexion extension, provide 3 repetitions of each exercise, and the resident is not able to help with exercises. Remember, we're looking for which body part, which exercises, and how many repetitions. Every skill starts with an opening. We know to do this. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do some exercises on your leg. Is that okay? I'm going to go close your curtain, wash my hands, and I'll be right back. We'll evaluate if we need gloves. Patient might need gloves. If they're incontinent and I'm working on their legs, I need some gloves. If they are fully dressed, and remember for the test, you guys are all going to be fully dressed. Please remain fully dressed. And you're all holding on to your own body fluids like champs. So there's no real risk here for the test based on your patient. But in a clinical setting, you might need gloves because gloves always depend on the patient. Good. And then we're going to follow our test-specific steps. Move slowly and smoothly. Return all the way to start. Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. We'll ask about pain, and then we'll do our closing. All right, any questions? I'm going to show you the video for this one. We actually have, I'm super excited about this. Because this is a new room to us and you guys are the first group that's going through, I'm having to make some adjustments as we go because I don't have my clinical lab. But I just ordered. It's being delivered today. I'm super excited. We have a, it's like an ottoman, you know, like a footstool thing, but it opens up to a bed. So I'm going to have it right here. So on sometime today, we will actually have a bed to demonstrate skills on. I am super excited about this. I had to search for quite some time to find the right thing because I needed something that the head of the bed would go up. And there's not enough room in here for a whole hospital bed. So I had to kind of find something that would work. So I found it being delivered today. I'm so excited. So on Thursday, we will be able to actually demonstrate some of this live. Okay. So right now I'm going to show you the video for this.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Doing great. How about you?
Wonderful. I need to do some exercises on your right hip, knee, and ankle. Is that okay?
Yes.
I'm going to close your curtain. Let me go wash my hands, and I'll be right back.
Okay.
Okay, I'm going to do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay?
Okay.
The first exercise is going to bend your knee up to your chest and back down to the bed like you're climbing stairs.
Okay.
We'll do this 3 times.
Okay.
Please let me know if there's any pain.
All right.
I'm going to support under the knee and under the ankle, and we're going to lift and bend all the way up and all the way back down. Feel okay?
Yes.
We're going to do this again, all the way up and all the way back down. Still okay?
Yes.
One more. All the way up and all the way back down. Next exercise we're going to do will be on your ankle. I'm going to lift your foot off the bed and we're going to bend forward and backward like you're stepping on a gas pedal.
Okay.
We'll do this 3 times.
Okay.
So I'm going to lift and we'll bend forward and backward 1, forward and backward 2. Feel okay?
Yes.
And one more. Okay, any pain or discomfort?
No.
Is there anything else I can get for you while I'm here?
No.
Magazine perhaps?
No, thank you.
Okay, let me get your call light for you, and I'm going to open the curtain.
All right, thank you.
Here's your call light. If you should need anything at all, please let me know.
Thank you.
I'm going to go wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right. Any questions? Any questions? Range of motions are the easiest skills we do. And thankfully, you're probably going to get one on the state exam. Remember that when you go take the test, they're going to give you one documentation skill. We've talked about that. Pulse, respirations, feeding, or drainage bag. You will get one of those. Everybody gets a documentation skill. But you will also get one mobility skill. Now, mobility skill is range of motions, walking a patient, ambulating with a gait belt, transferring from bed to wheelchair, or turning a patient over to that sideline position. So you're going to get one of those 6. One of those 6 you will get. And then what's left is ADL skills, and you'll get one of those as well. So that's foot care, hand and nail care, dressing, partial bed bath, peri-care, catheter care. Good? Questions? All right, this is everyone's least favorite skill. Nobody wants to do this skill. And this is performing mouth care to a resident with dentures. So if you turn to page 96 in your book, that's okay. I'm just going to show them dentures. So let's talk a little bit about dentures. I know it's not pleasant. I get it. But if your patient has dentures, they've got to be cleaned. You can't have them not cleaned. That's just gross. So we're not just going to clean the dentures. We're going to clean the mouth the dentures came out of. Now, all of you in your kits have a denture simulator. So there's a little plastic, teal plastic cup, and in it are fake dentures. They're not real. Don't put them in your mouth. They're just there to allow you to practice denture care. Good? Questions? Okay. So when we look at page 96, you can see that there's a lot of steps involved, a lot of principles involved. We're going to follow the care plan. We'll do our opening. Gloves will be required for this because body fluids. We're going to use a barrier. Linen rules are going to apply. We need a towel and a washcloth for this, so don't hold them up against your uniform. Don't throw them on the floor. We're going to clean our basin the way we clean everything else. This is mouth care with an extra step. That's all this is. And we're going to do the closing. So your skills specific, let's go ahead and concentrate on those right now. If you look at the care plan at the top, page 97, it gives us our instructions. It says a resident with dentures is sitting at an overbed table with their dentures in a denture cup. The resident's denture needs to be brushed with toothpaste, and the resident needs mouth care. The resident's denture is stored in a denture cup after cleaning, and the resident is not able to provide their own mouth or denture care. Step-by-step instructions are there. If you just follow these instructions, you will get 100% on the state exam. But denture care means we're going to clean both the dentures and the mouth they came out of. Now, there's a couple of different types of dentures, and I want to go over that with you guys real quick here. You always have to have gloves on when you're touching dentures because of body fluids. So do as I say, not as I do here. I don't have gloves on, but I'm going to show you this. So this is what most of us think of when we think of dentures. This is what we call a full plate. All of the teeth have been replaced. And this is what we tend to think of when we talk about dentures. But not everybody has a full plate. If we still have some good healthy teeth, we don't pull good healthy teeth, usually, to replace everything. In that case, if the patient has some good healthy teeth, they would have something like this. This is called a partial. Now you can see that we have some replaced teeth, but there's also some gaps here to fit around the good healthy teeth that remain. We try to keep people's good healthy teeth as long as possible. We don't just pull them out. Good? Make sense? So full plate, partial. Now there's also something else called a bridge. A bridge is a small piece of denture, just a little tiny piece of a denture that would replace one or two missing teeth. And usually they have hooks on them to clip to the other healthy teeth that remain. So this is going to replace just a few teeth. This is going to replace more, but not all. And then this replaces all. We clean them all the same way, but it's important that you understand there are some differences there. Good? Questions? Okay, so this skill is going to require 2 sets of gloves. You need 1 set of gloves when you're cleaning the dentures. But once we've cleaned those dentures, those gloves, are they now clean? Would you want those gloves in your mouth? No, that's pretty gross, right? So we're going to get a clean set of gloves for the patient's mouth care part of the skill. Good? Questions? So when it comes to dentures, there's two ways of cleaning. Most of the time, your patients are just going to want their dentures put in a denture cup like this, filled with water and those fizzy tablets. Those fizzy tablets are specially designed to break down all of the proteins, the food particles, the denture paste, all of that. And it gets into, because they're fizzy, those little bubbles get into all the little cracks, and it actually does a really good job of cleaning dentures. So fizzy tablets is one way of cleaning dentures. The other way is a good old-fashioned toothbrush and toothpaste. This is just like, you know, your own mouth care, except it's at the sink. The method you will use will be indicated on the care plan. It depends on the material that the dentures are made out of, because some dentures, if you brush them with toothpaste, toothpaste is very abrasive. And if you brush dentures with toothpaste, it can actually cause micro cracks to form, which is where bacteria is going to hide. So some dentures, we don't use toothpaste and toothbrush. We use fizzy tablets. Other dentures, we would use toothpaste and toothbrush. It depends on the patient, what they have, and we would find that information out in the care plan. Follow your care plan. But this care plan tells us to use toothpaste and toothbrush, so that's what we're going to use. But we're going to use a very special kind of toothbrush. Now, you guys all have this in your practice kit. This is called a denture brush. That denture brush is a double-sided toothbrush. One side looks like a toothbrush. The other side is much smaller. This part is going to fit in the channel part of the dentures, the indented part. And it's specially designed for that purpose. The toothbrush side, that just cleans the teeth part. Good. It's hard to fit this in the channel. So they give you a brush that has a smaller edge to it. But when it comes to cleaning the patient's mouth, especially if they don't have any natural teeth left, we don't normally use toothbrushes to clean the mouth. You can, there's no problem with it, but dentures are usually held in place with denture paste. Denture paste is stringy, gummy, very sticky. And when you try to use a brush to get that denture paste off, that denture paste gets all caught up in those bristles, and it's really hard to get all the gums clean with a brush. So we generally use something like this. You have one of these, actually you have two of these in your kits. These are called toothettes. They're soft and spongy, but they're solid surfaces. So you would take this surface, wet it, put a little toothpaste on it, and then you're just going to swipe it along the gums, and it'll capture all of that denture paste. And then you can turn it and swipe another gum. And then you can turn it and swipe a third gum. And then you can turn it and get the fourth gum. So 1, 2, 3, 4. So these are usually used when we're doing mouth care on a patient with dentures. You can use toothbrush and toothpaste. There's no problem with that. It's just that because you're not at a sink, it's really hard to clean that gooey, gummy paste out of your toothbrush because you're not at a sink. Good? So we're going to treat this like a two-part skill. The first part of the skill is we're going to go over and clean the dentures at the sink. We're going to wet our denture brush, put some toothpaste on both sides, take it in the basin over to the sink. You've got to have a basin to hold that brush. You can't just lay a denture brush on the side of the sink. Why? It's not clean. So that basin's just going to hold your denture brush while you're getting your water on and doing the other steps we have to do. So the basin's just going to hold that prepared toothbrush. Don't put it on the side of the sink. That's pretty gross. Now, when we're at the sink, we need to put a washcloth in the bottom of the sink because those dentures are about to get really slippery. And if you drop the dentures and it hits the bottom of the sink, they're likely to break. And if you break the dentures, the facility has to get new ones made. And dentures are right around $5,000. They're expensive. They're really expensive, especially if they're, the really good quality ones. So we've got to be really careful not to break our dentures. But even worse, way worse than that, is that while the patient's waiting to get new dentures, they don't have any teeth. That makes eating really difficult. So the patient's going to be put on a pureed diet. This is where we chop up all of their food really fine, and they would eat without having to chew. So that's really gross for somebody who is used to eating with teeth, which means that they probably won't eat very well. Make sense? Makes sense. I want to talk to you real quick about dentures. If your patient has dentures, they have to be able to take them out by themselves, and they have to be able to put them in by themselves. CNAs do not take dentures out, and we do not put them in. That's not our role. Patients have to be able to do that. If the patient can't do that, then the care plan would call for the food to be pureed. Patients have to be able to take dentures out and put them in. And the reason for that is this. When you have, especially on the bottom, a bottom plate, top is bad too, but the bottom is the worst. When you have a bottom plate in, it's going to be held in with suction and paste. And it really sticks in there. That allows you to chew without the dentures flopping up and down. So they're stuck to your bottom jaw. Now, if I'm going to get my own dentures out, I would put my fingers all the way in the back like this, get the back corners of those dentures and pop them up and forward. But in order, my fingers have to be way back here. Make sense? Now that's fine for me because the leverage I'm using isn't pushing down on my lower jaw. It's just my fingertips. Now you see the position my fingers are in here? If I do this on somebody else, my fingers aren't like that. They're like this. They're not upside down. They're like this. And when I put my fingers in like this, these two knuckles, in order for my fingertips to push up, these two knuckles have to push down for leverage. And when you push down with these knuckles on that lower jaw, as you're trying to pry that denture off of the gums, you can dislocate their lower jaw because you're not aware of how much pressure you're pushing down with. So there is a risk there of dislocating the patient's jaw. That's why patients have to be able to take them out themselves. As far as putting them in, when you put dentures in, your reflex is automatically to bite down to seat those dentures. It's just reflex. You can't really help it. It's a reflex. Well, if your hand is inside somebody's mouth and their reflex is to bite down to seat those dentures, what do you think is going to happen? Yeah, you're going to get bit 100%. They don't mean to do it. It's a reflex. So your hand should not be in their mouth when dentures are being seated. So CNAs don't put dentures in and we don't take them out. Our job is to clean them and to store them. That's our job. So when we're cleaning them, we want to keep them safe. We're going to put a washcloth in the bottom of the sink. If you can get it over the drain, even better. Because if you get it over the drain, the sink actually starts to fill up with water. And if the dentures fall, they fall onto the water, not the hard surface. We're going to use a paper towel to turn that water on. Again, your hands have been cleaned. You don't want to touch that faucet. And we only want to use cold water, not hot. There's a principle here. If you go in for nursing, you'll learn this. Heat coagulates proteins. All that means is when you use hot water, it makes everything stickier and harder to remove. We don't want hot water when we're cleaning dentures. Cold water. Good. Of course, gloves need to be worn. We don't touch dentures without gloves. But when we're holding the dentures, you really want to make sure you're holding them and keeping them from falling. Be very, very careful. You can handle the denture cup without gloves, sure, no problem. But you can't handle the dentures without gloves. Remember, the first thing your gloves should touch is the patient, or in this case, the patient's teeth. So one of the biggest issues with testing with this is that people will put their gloves on before they take the denture cup over to the sink. They put the washcloth in the bottom, they turn the water on. So by the time they touch these dentures, what's wrong with their gloves? Oh, they're dirty. Absolutely. Make sense? That's the most common testing error with this skill. Are you guys starting to see that you're able to answer the questions that I'm asking? You really are prepared for the state exam. You don't have confidence yet. You will develop that. But I'm telling you, you really are prepared for that state exam because you're able to give me these answers. You would not touch dentures without gloves. You just wouldn't. Make sense? Okay. So we're just going to brush everything we see. Doesn't matter what order you do it in. I don't care. Nobody cares. Just get the whole thing covered in toothpaste. These are clean dentures. They're real dentures, yes, but they're not actually worn by real people. There's no food particles. There's no denture paste. They're all clean. Just get them all covered in toothpaste. Brush all surfaces. And then we're going to rinse. Never set a denture down in the sink. That denture can only be in two places, a cup or your hand. That's it. Don't ever set them down in the sink. Don't put them on the side of the sink. If you can't hold them, they need to be in the cup. Okay. All right. We're going to rinse the denture cup, fill it up with cool water, put our dentures in the denture cup, but that cup is wet. We've rinsed it. It's wet. If I put a wet denture cup on a piece of furniture like this, what's going to happen? It's going to get it wet. Grandma probably has you use a coaster on all of her wood furniture at the house. Why? That's right. It'll leave a ring. It'll warp the wood. That's exactly what's going to happen here. And housekeeping is not going to like us if we go around destroying all the furniture in our facility. So when we have a denture cup and it's wet because we've rinsed it out, before we set it down, we want to put a paper towel under it so that when we put it on any surface, it's not going to warp that surface. So paper towel under the denture cup is actually pretty important.
Do you put water in it though for the dentures?
Yes, dentures have to be stored in water, cool water. So we're going to brush the dentures, hold it, rinse the denture cup out, fill it up with water, put the dentures in, put the cap on, and put a barrier underneath.
What if you forget to put the paper towel under it? Do you just clean it up?
Yeah, yes, if you address it, that's fine. You know, so if you because the test is stressful. So let's say that I'm over here. I'll play this out for you. I'm over here at the sink. I clean my dentures. I rinse my denture cup. I get water in it. Oh, there's water in it. Get water in it. I put my lid back on and I carry it over to the table. And I put it on the table. And there's no coaster under it. And then I go back to the sink, wring my washcloth out, put it in dirty linen. I take my emesis basin, holding the denture brush back over to the table. And while I do that, I realize, uh-oh, there's no coaster here. I can stop and get a coaster. Not a problem. If at the end of the skill, you look around, before you end your skill, you look around, make sure your environment is clean, and you see there's no coaster. Go get one. Put it under there. If you don't address it at all, if you just have a cup on a table, no paper towel, it's not a failing step. It would be a deficiency, but it's not going to fail you. But housekeeping won't like you. Okay. So good? Good? We have to put the washcloth in dirty linen. Can we put it on the floor? No. So we're going to wring it out, put it in dirty linen, and then we're going to grab our basin that's just holding that denture brush and bring it over to our table. Now we need that basin because remember I told you denture care is 2 parts. There's cleaning the dentures. What's the other part? What else do we need to clean? Their mouth. And in order to do mouth care, they have to have somewhere to spit. We need that basin. So you've got to make sure it's over on the table before you start brushing the patient's teeth. And then we're just going to brush their teeth the same way we did before. We're just going to use a different type of toothbrush. We're going to use that toothette. So we dip it in water, we put some toothpaste on it, we get a towel over the patient and get our gloves on. And then we brush. Remember, the first thing the gloves should touch is your patient. So do all that prep work first and then get your gloves on. Then we're going to pick up that toothette and we're going to brush whatever the patient's got. Whether it's just gums, teeth and gums, or teeth, I don't care. Brush whatever's in their mouth. Then we'll let them rinse, spit as often as they need to, dry their mouth off, and then we'll clean up. This is the skill that nobody wants to do. I get it. It's probably my least favorite skill. But in all actuality, it's a pretty easy skill. It's a pretty easy skill. You already know how to do mouth care. We're just adding in an extra step. Okay? Good? So for those of you joining us at home, all of my students have this. They have this kit. And one of the things that's in the kit is a Smalls package that has all of this. They have a denture brush. They have a toothette. They've got some toothbrushes, orange sticks, emery board, chucks, gait belt, emesis basin, everything you need to practice. So if you're watching us from somewhere else and you're not in a clinical classroom to practice these things, you probably want to get a practice kit so that you have all the things you need to be able to practice these skills. So when you go to the test, you've practiced each skill before you got there. Okay, so all of you guys have these. All of you guys either need to be in a clinical unit practicing, or you probably need to get one of these to make that happen. All right, so let's go ahead and watch Denture Care.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing good. How about yourself?
Wonderful. I need to do denture care on you. Is that okay?
Yes.
I'm going to take your dentures to the sink. I'm going to close the privacy curtain and wash my hands. I'll be right back.
Okay.
Okay, Mr. Jones. I'm going to place a barrier on the table so we have a clean area to place the clean supplies. And then I'll gather the supplies that I need. We'll need a cup of water, a toothette, a denture brush, toothpaste, a basin, a washcloth and a towel, and 2 sets of gloves. Okay, we're going to get the denture brush ready for use, so I'll wet it. and apply a little bit of toothpaste to both sides. We'll allow the basin to hold that denture brush until we're ready to use it. I'll be right back, Mr. Jones. I'm going to go clean your dentures.
Okay.
Okay, Mr. Jones, I'm just going to set your dentures over here so that you have them if you should need them later.
Okay.
I'll place the denture brush on the barrier, and now we'll remove these gloves. And we'll throw those away. Do you mind if I place a towel over your chest?
That's fine.
This will help keep your clothing clean.
Thank you.
We're going to prepare for the mouth care portion of this skill. We'll take the toothette and wet it. Apply a little bit of toothpaste to one area of the toothette and apply gloves. Okay, Mr. Jones, I'm going to brush all surfaces of your teeth now. So in a moment, I'll need you to open your mouth wide so that I can reach the back teeth.
Okay.
Okay, can you open your mouth? Thank you. I'm going to brush the back on the bottom and on the top, both sides. Okay, can you bring your teeth together, please? Thank you very much. We're going to throw the toothette away. And would you like to rinse? Very good. Would you like another rinse?
Yes, please.
Another rinse?
No, thank you.
Okay. I'm going to remove your towel and we'll place this in dirty linen. We'll throw away the disposables. And now I'm going to clean your basin. I'll be right back.
Okay.
I'll place the denture brush and the toothpaste in the basin. and open the drawer with a paper towel to store the basin and other supplies. I'll remove the barrier from the table, and we'll throw this away as well. Now I can remove my gloves. Mr. Jones, are you comfortable?
Yes, ma'am.
Can I get you a magazine?
No, thank you.
Is there anything else that you need?
No, thank you.
Your call light's right there. If you should need anything, just let me know. I'm going to open your curtain and go wash my hands.
Thank you.
After washing my hands, I'll think about the steps of my skill, make any corrections, and then tell the evaluator my skill is done. All right, any questions on that? No questions? Okay. We're going to go ahead and take our break. We will have about 45 minutes of practice time at the end of class today. I do know that inauguration starts at 12. So anybody that needs to, step out to watch that, feel free. But we will have about somewhere around 12:15 usually is when we break for practice. So go ahead and take your break now. We are running a few minutes ahead of schedule, so hopefully that'll work out. Come back in 15 minutes.
No, it's not. It feels illegal. He says he spends every Friday there or something.
Okay. So this next skill that we're going to learn is ambulate with a gait belt. I need to borrow a chair to make this work. In just a few minutes, Jake, I'm going to need follow me. I'll let you know when. All right. So the next skill that we're going to learn to do is ambulate with a gait belt. Ambulate is just a fancy word for walk. So this isn't a hard skill. You're walking somebody. We're going to use a gait belt. We have to learn how to use that. But the why behind this skill is actually more important than the how. And that's what I really want to try to focus on right now is why certain steps are important. And in order to understand that, we have to talk a little bit about energy conservation. So this is one of those topics that's really kind of hard to grasp unless you really are thinking actively about it. And in order for you to understand this, I have to talk to you about 2-year-olds. Anybody ever see a 2 or a 3-year-old? That was my favorite age. I love that age because they're starting to develop independence. Now, we usually call it the terrible 2s because their favorite word is no. Absolutely. The reason their favorite word is no is because they have no control over everything. And by saying no, it's a way of them exerting control. This is a really cool thing. I love 2-year-olds. Now, the other thing about 2-year-olds that's pretty cool is that they are so full of energy. I mean, they have got energy to spare. 2-year-olds will jump up and down for no reason. No reason. They will just bounce in place because they've got all of this extra energy. When was the last time you bounced up and down? Yeah, probably when you were 2. Now, if I win the lottery, I'm jumping up and down, but I got a reason then. I'm not doing it just because I've got excess energy. The problem is, if you've ever tried to explain to a 2-year-old why you don't have the energy they do, how does that conversation go? Yeah, they don't understand. They have never experienced a lack of energy, so they have nothing to compare it to. Does that make sense? So you trying to tell a 2-year-old, I'm so sorry, I just don't have that energy. They're like, that. You might as well be speaking Martian because that it doesn't compute. Good? Everybody with me? That's important. I'm going to come back to that in just a minute. So remember that. Try to explain to a 2-year-old why you don't have that level of energy. They don't get it. But the thing about energy is you actually max out somewhere around 2. That is like the most energy you will ever have in your whole life. And I'll prove it to you. Let's go out 10 years. Let's talk about 12-year-olds. 12-year-olds, they still have a ton of energy. They skateboard, they play basketball, they play video games, they have synchronized dance parties, like they do all kinds of stuff, right? But you put that 12-year-old in charge of that 2-year-old for one afternoon, who wins? 2-year-old. Absolutely. So what does that tell us about our energy levels? Yeah, we have decreased energy in that 10-year period. You had more energy at 2 than you do at 12. Now let's go out another 10 years. Let's go out to 22. Now 22-year-olds will go out shopping all day, marathon shopping, and then they'll go out at night looking fabulous, wearing what they just shopped for, right? There's still tons of energy. Tons of energy. But that 22-year-old does not have the same energy that they had when they were 12. Let's go out 20 years now. Let's go to 42. Now, 42-year-olds will shop till they drop, but that's like 3, and we're not going out tonight. We're done, right? Our energy levels have dropped. Now let's go out to 62. Now at 62, we're putting our feet up before we make dinner. We're starting to think about retirement because there's just not enough energy to do all of that work as well as all of the work you have to do at home. You know, your energy levels have severely decreased. So you're starting to think about things like retirement. Your energy levels have dropped. So what do you think your energy level is going to be like when you're 82? Yeah, very little, right? Our energy levels have dropped. Now, I want to make sure that you understand that there are outliers here, right? This doesn't happen to everybody. I knew my best friend's husband's grandmother. I know that's a stretch, but my best friend's husband's grandmother was in her 90s, still drove, did all the grocery shopping, did all the laundry for the entire household, babysat her great grandson and drove him to and from school well into her 90s, sharp as a tack. Is that what we would consider normal? Probably not. That would be an outlier. Make sense? So I'm not saying that this happens to everybody, but in general, our energy declines through our lifespan. Now remember, back when you tried to explain to that 2-year-old about your energy lack and they didn't get it, when that 82-year-old tries to tell you, remember, you're way up here, look how much energy you've got. When that 82-year-old tries to tell you, oh, honey, I don't have the energy for that, you aren't going to get it. Just like that 2-year-old didn't get it. They might as well be speaking Martian to you because you weren't aware that energy levels dropped over the lifespan. Make sense? I give you this lecture so that you understand energy levels do drop. And this becomes very, very important when we're caring for older individuals. But, you know, they're old, right? They got nothing to do and all day to do it. I mean, why do we care about their energy levels? Well, in order to figure out why we should care about their energy levels, we have to start thinking about the things that we do every day that take energy. So what are some things that we do every day that takes energy? Yeah, everything, but eating. Have you ever been too tired to eat? If you've ever been too tired to, that means it takes energy. Have you ever been too tired to talk? Okay. Usually on Mondays and Wednesdays, by the time I get home, I'm done because I talk nonstop for 4 hours. I'm done. I don't want to talk no more. So yes, you can be too tired to talk. You can be too tired to eat. What about getting out of bed in the morning? Does that take energy? I swear that takes half of my energy. I like my bed, right? But what about things like showering? Does that take energy? Have you ever been really, really sick, like laying on the couch for 3 days, feeling like you're half dead, really, really sick? And the thought of a shower is just so overwhelming, right? That means that simple action, something we do every day and don't even think about, takes energy. And then there's things that we, that are very evident, like walking takes energy. Getting dressed takes energy. But things that aren't quite so evident, things like breathing actually takes energy. Digestion takes energy. And we know that because we learned a couple of classes ago about the need to burn calories to maintain our body heat, right? So just digestion takes energy. So everything that we do takes energy. Now, if we go back a slide real quick, and you've only got this much energy, and you've got to do all of this every single day, we may run out of energy somewhere in there. It's possible. And if we have an older patient that does better in the mornings, do I have any morning people here that really like mornings? They get up and they are productive and Yeah, you guys are strangers to me. I am not that. Right? I come alive about 4 in the afternoon. Usually somewhere around 9, 10 o'clock at night, that is when I am the most productive. Right? I am a night person. That's just how I'm wired. I am not a morning person. But those of you that are, if we try to give you a shower at night and you've already used up all of your energy for the day, you're probably going to tell me, oh, I don't have the energy for that. And remember, if I'm way up here on the energy scale, I'm not going to understand that because all you're doing is sitting there. I'm doing all the work. Why won't you let me shower you? Because even just sitting there takes energy. Good? Makes sense? So when our patients say, I don't have the energy for, fill in the blank, we have to believe them. Maybe we can rearrange the schedule a little bit and shower that person in the mornings when they have more energy. Or shower somebody like me in the evening when I come alive. Right? But this is also why a lot of our older individuals will eat their bigger meal earlier in the day, like around noon. Their lunches are bigger, their dinners are smaller, because by the end of the day, they just don't have the energy to digest the food as well. Now, if we force our patients to do everything we need them to do on our schedule, and they don't eat well in the evenings because they're just tired out, what do you think that's going to do to tomorrow's energy levels? They'll be lower. That's right. And because their energy levels are lower, they're not going to eat as well today. So what do you think that's going to do to tomorrow's energy levels? This is what this is a downward spiral, and it happens a lot. And this is how we get failure to thrive in older individuals. So we have to start listening to our patients. Good? Makes sense? Without this lecture, CNAs tend to try to force patients to do things because they're thinking with their energy levels, not with the patient's. So, have you ever seen an old person try to get up out of a chair? Jake, I need you to follow me, please. Okay. Oops. This works better with a chair that's not on wheels. Bear with me. All right. Have you ever seen an old person try to get up out of a chair? Right? It usually does something like this. They start to rock. And then they try to get up. Nope. And they go back down. And they rock a little more. How much energy did that take? A lot, right? I had to get up out of the chair twice, and I had to do all that rocking. All of that took energy. That took way more energy than if I had just stood up. When your strength decreases, effort has to increase. Always. There's an inverse relationship there. Anytime your strength decreases, effort or energy has to increase. Now, let's think about how many times an older patient gets up out of a chair on any given day. Well, they have to get up out of bed and they have to go to the bathroom, which means they're down on the toilet and then they have to get off the toilet. And then they go sit on the edge of their bed to get dressed. So they sit on their bed and then they have to get up. And then they go back into the bathroom to brush their teeth. And then they go to breakfast where they're sitting, having breakfast, and then they have to get back up. And then they go to an activity where they sit and they get back up. And then they go lay down for a little rest before lunch. And then they have to get back up. And they go to the bathroom and they have to get back up. Can you, we haven't even got to lunch yet, guys. You see how many times they had to get out of that chair? And if each one takes that amount of energy, oh, by the time we get to like 2 or 3, we're done. We're out of energy. So we have to have processes in place to help our patients conserve energy, and that will get them through the day. Good? Does that make sense? That's what this is all about. So our skill here is ambulate a resident with a gait belt. This is going to help us stand the patient up, because when energy goes down, effort has to go up. So instead of making the patient work harder, we're going to give them some of our strength, and we're going to help them stand, which helps conserve energy. And if you do this every time they stand up, that little bit of energy that we're saving with each one of those get ups can actually make a big difference. Good? Does that make sense? So that's why we use a gait belt. Now, when do we know when we should use a gait belt? The care plan, sure, absolutely. So when you're looking at this particular skill, you can see all of the skills specific. We're going to get into those. And then across here, you can see all of the principles that are involved with this particular skill. Again, I've got a video for this. And down here, you can see test-specific information. So we're going to ambulate a resident with a gait belt. Tess is going to give you 5 minutes to do that. It's going to be done on another testing student. And they're going to be sitting in a chair at the beginning of the skill. So we have to talk a little bit about shoe rules. This is our last principle. We went over some of this. We're going to finish it up today. And we already know if the patient's feet hit the floor, we got to talk about the shoes. We know that. Slipper socks are not enough. We've learned that. But the rest of them have to do with a gait belt and with this whole process. So let's learn each one of these principles. So if you look at the top page 67, you can see our care plan. It tells us to ambulate the resident at least 10 steps. It's round trip, guys. So it's 5 steps in one direction and 5 steps back. Round trip. Use a gait belt or transfer belt. The patient will be sitting in a chair at the side of bed with shoes on. So we don't even have to put their shoes on. They're already on, but we do have to talk about them. I see you have shoes on. Do your shoes fit well? Right? We have to talk about them. Patient's able to walk, cool, but needs assistance to stand. There's that strength that we're going to provide to help them stand. Questions so far? Step-by-step instructions tells you exactly how to do this. So when we're putting a gait belt on a patient, we need 4 fingers between the gait belt and the patient. Their feet must be flat on the floor before we help them stand. We're going to count to 3 before we lift them to a standing position. And once they're standing, we want to ask, are you dizzy or weak? The patient must feel the chair. That's okay. The patient must feel the chair behind them before they sit. Why would that be important? Yeah, so if you ask me, like you back me up here, and you ask me to sit down, and I don't know, I'm not touching that chair. I have no idea if there's something behind me that's going to catch me. I'm going to stiffen up. I'm going to be resistant because I'm afraid I'm going to what? Fall. Absolutely. And unfortunately, most patients in a clinical setting have been dropped. They don't trust you. They do not trust you. So if you are going to ask somebody to sit in a chair, they have to know that that chair is actually there. So you're going to have them back up until their knees hit that chair. And then they're not going to resist when you help lower them into the chair. Does that make sense? This is a super important step that a lot of students miss on the exam. The patient has to know the chair is there. Otherwise, they'll resist. All right, and then we're going to use proper body mechanics. I'm going to talk to you about those. So, of course, we know slipper socks are not enough. And let's learn how to put a gait belt on. So in your kits, I want you to get your gait belts out. It's a flat canvas belt. It's going to be folded over, wrapped in plastic. Looks like this. It's like Christmas. Okay, can I borrow yours? Because I don't have mine. Okay, so this is what a gait belt looks like. Yours is going to be very stiff. Over time, these do loosen up quite a bit. The canvas becomes easier to work with. So when you're first learning to work with this, it's going to be a little bit difficult because they are so stiff. The best thing to do when you're sitting in front of your TV tonight, just take your gait belt and just start working with it like this. Just kind of move it back and forth to loosen up that canvas, and it'll actually make it a little bit easier to work with. So if you do this for, you know, a little bit here and a little bit there, it will make it easier for you to practice with. Now for the test, you do not have to take your own gait belt. The testing center has a gait belt there. It's well used. It'll be easy to work with. But this is going to help you when you're working in a clinical setting. It's always best to have your own gait belt because they tend to walk away quite often, and then you can't ever find one in a facility when you need one. So having your own gait belt is a good idea. So when you put this around the patient's waist, this goes around the patient, not you. But I'm going to demonstrate on me just to show you, okay? When you put this around the patient's waist, you're going to do it so that the tag, see that tag, goes in, just like any other article of clothing. The tag is going to go in. It doesn't matter whether the buckle is facing this way or the buckle is facing this way. Nobody cares. Nobody cares. But you want the tag in. So you put this around the patient's waist. When you do, when you put this around the patient's waist, not yours, I'm going to demonstrate on me, you want to make sure that it's flat. So do you see how that's flat behind my waist? It's not twisted. You don't want it twisted. You need it flat. So when you get this around the patient's waist, you're going to put the free end here through the first guard by the teeth. So it goes right up through by the teeth. And then if you look, all those teeth point that way. You see how the teeth are pointing? That tells you which way to pull this to tighten it. If I try to pull it this way, it's not going to tighten. You tighten it. Now this has to be snug. This is not snug enough. If I go to lift the gait belt, it's going to go up underneath the breasts or under the arms, or the patient will just slide right out. We want this to stay in place. So in order to get it snug enough to stay in place, you need to pull it, and the 4 fingers are all that should fit between the belt and the patient. 4 fingers like this. If it's too loose, your patient is at risk of falling. Too tight, they can't breathe. But too loose is a much bigger issue. Make sense? So once I get it snug enough and I've checked it with 4 fingers, then I take the free end and put it through the second guard, like this, through the second guard, and that locks it in place. This tail, if it's hanging down and in your way, you can just tuck it up. So let me do that again and show you. Jake, can you zoom in? Okay. Okay. So can you see it on the screen? Everybody see it? Okay, so you take the free end, put it through the first guard by the alligator teeth. And then you pull it so that it's snug. You check it with 4 fingers. 4 fingers. And then you put the free end through the second guard And this tail, if it's hanging down too long, just gets tucked up into the belt to get it out of the way. To remove a gait belt, you're going to slide it out of that second guard. But to remove a gait belt, we want to move the buckle, not the free end. Remember, to tighten it, we pulled the free end. To loosen it, we have to pull the buckle. So I'm going to hold the buckle, top and bottom, and slide it. Stiff. Slide it along the canvas. Okay. So to tighten, we pull the belt. To loosen, we slide the buckle. That's why when they're really stiff, it's hard to slide. So you're going to want to practice this. We'll remove the belt from the patient, but we don't slide it. Listen to the sound if I slide it. Do you hear that? That's going to tear skin. It can leave a burn. We don't pull it against. You want to loop it up and over, holding that buckle. You don't want to hit them in the head with the buckle. Loop it up and over, or you can reach around the back and grab it, but don't slide it against the skin. Questions? Everybody good with how to use a gait belt? Okay, I want you to take just a couple of minutes using your gait belt. Practice putting it on a neighbor.
Thank you.
Thank you.
You're live.
Okay.
What if the person's mobile and can walk and get up, but the belt don't fit around them?
Okay, so remember we use a gait belt. When would we know when to use a gait belt? The care plan.
Oh,
So if the care plan doesn't tell us to use a gait belt, one is not needed. So if they're up and mobile and walking on their own and they don't need our assistance, then we probably won't be using a gait belt. So in that situation, CNAs only have two options. We follow the care plan or tell the nurse. So who would we tell? The nurse. We actually have bariatric gait belts that are longer. Yep. I'm going to show you. Yep. How do you lift them? We're going to talk about body mechanics now. Everybody good on how to put a gait belt on? Make sense? All right. So before we lift a patient, have a great day. Before we lift a patient to a standing position, you have to make sure their feet are flat on the floor. Now, what I mean by that, follow me. What I mean by that is if you look at me, and can you focus on my feet? There we go. Okay. Okay. If you look at my feet, I'm short. My feet are not flat on the floor. When I sit all the way back against the back of a chair, my feet do not go flat on the floor. And it may be hard for us to see on the camera, but I'm kind of on my tiptoes. What do you think would happen if somebody pulled me forward and I'm on my tiptoes? I'm going to fall forward because my weight is not evenly balanced. So we have to make sure your patients don't assume, and you that are taller probably wouldn't even think about this because your feet hit the floor. You wouldn't think that other people's feet don't. People with short legs, and somebody that is 5'6", which is average height, may still have this problem because they have a long torso but short legs. So we always address this. It doesn't matter how tall our patient is. We always address this. Are your feet flat on the floor? And if they say no, we just ask them to scoot forward. And then their feet are now flat on the floor. And this is the position somebody has to be in to be lifted for stability. Good? Makes sense? So we're going to ask, are your feet flat on the floor? Remember, we have to talk about shoes. I see you have shoes on. And we want to ask, are your feet flat on the floor? Now, once we have that addressed and we have the gait belt around the patient, we're going to use that gait belt to lift our patient to a standing position. But in order to do that, we have to use a very specific type of body mechanics. It used to be years ago, we would teach you to stand right in front of the patient, toe to toe, so their feet don't slide out, and knee to knee, so that we give them stability. And it sounds good, doesn't it? Except for physics. Physics taught us back in high school that every action has an equal and opposite reaction. Does that make sense? So if I am lifting a patient up from a seated position and that patient is 150 pounds, I am lifting 150 pounds of force toward me. That means that my body will go 150 pounds backwards. And my back has to stop that. My back bending to stop that force will eventually cause back issues. It wears down the discs in your back. So that's not good body mechanics because of physics. So if we can't stand in front of somebody, how do we keep their feet from sliding out? And how do we lift them to a standing position, providing some stability? And that's what we have to learn now, is proper body mechanics. It's not the way it used to be. We've learned. Okay. We're going to make our patient a partner by counting to 3. So I've got their feet on the floor. I've got the gait belt on. I'm going to use proper body mechanics. I'm going to lift them up. But before I lift them, I want to count to 3. 1, 2, 3. And on 3, we're going to lift. Always make your patient a partner. If you try to lift somebody and they're not cooperating, this can hurt you. It can hurt them. And it just makes this whole process much, much more difficult than it needs to be. So in order to make this work, we're going to stand at an oblique angle for stability. And the way this works, do you see how this person is not standing right in front of our patient? The way this works, is that we are going to put one foot across perpendicular in front of their feet. The other foot goes beside their chair. So over here, I need floor view again, Jake. So if we've got somebody sitting in the chair, we're going to pretend somebody is there, okay? This foot would go like this in front of their feet. It keeps their feet from going out. This foot goes parallel to the chair. So if I'm standing here, I look like I'm standing at the corner of a box, one foot along each side. When I do that, this foot is going to keep their feet from sliding out, but I'm at an angle. Their body isn't pulling me off balance. So I would bend at the knees, not at the back. We don't ever bend at the back. It's always the knees, and that gets our legs to do our work, not our back. So we're going to bend at the knees, grab the gait belt from behind, their hands on my shoulders, and on the count of 3, we're going to lift. 1, 2, 3. That keeps me stable. It keeps my patient secure, and it doesn't force either one of us off balance. Good? Good. Okay. All right. Once we get the patient standing up, we got to make sure that they're not dizzy. When you stand a patient up over here, they're standing. If you start to walk them somewhere and they're dizzy, you have no exit strategy. What are you going to do? Now, most of you would try to hurry that patient back to the chair. It sounds reasonable, right? You want the patient sitting. You don't want them to fall. But if the patient isn't tolerating a slow walk, they are absolutely not going to tolerate a fast rush. So if the patient gets dizzy or weak or nauseous or whatever, while you're walking, don't hurry them back to the chair. You want to sit them down wherever they are. Get them sitting on the floor. Whatever they come into contact with, we can wash off. That's okay. We have soap and water available. We can't wash off a broken hip. Get them sitting on the floor and send somebody for the nurse. Don't try to rush them back to the chair. That will be a written test question. Most falls happen when the CNA tries to rush a patient back to safety. You've got safety right there. Get them on the floor. Okay, good? Questions?
Is there like a proper way to get them on the floor?
So the way, use whatever means you have with you. You can turn the patient around and slide them down the wall, particularly if they're bigger than you. That's a good way. But if I'm walking somebody, and we're going to get to this in just a second, but when you're walking somebody, they should be slightly in front of you, just slightly in front of you. And your hand should be underneath that gait belt. So I'm walking them like this. My focus is 100% on that patient, not on anything else, 100% here. Because patients don't just walk along, I'm good, I'm good, I'm good. It doesn't happen like that. Patients will tell you that something is going very wrong. They get pale. They get sweaty. They might start shaking. They'll probably put a hand up here or one here. They could even reach out for the wall, showing that they're unstable. They give you all kinds of clues that something is going very wrong in their lives, even if they're not verbally saying it. Your job is to pick up on those clues. Good? But if I see those clues, I'm walking slightly behind and to one side of my patient. My hand is in an underhand grip on that gait belt. And this hand tells me lots of information about my patient. Are they slowing down? Are they trembling? Are they starting to wobble? This hand gives me all kinds of information. But if something is going wrong, this foot, as we're walking, right? I'm walking. This foot goes right in between theirs. I pull them back against me, and now I am their stabilizing force. I'll hold them there for a second. You okay? I'm going to help you to the floor. We're going to lower to the floor. Ready? And I just slide them right down me onto the floor. If they're this tall, that may be a problem because, you know, there's a huge height difference. In that case, I might get them backed up against the wall and help them slide to the floor. Good? Makes sense? Okay. But ideally, that never happens because when we stand the patient up, if I ask them, are you dizzy? You feeling okay? If they say, yeah, I'm just not quite right, we aren't going for that walk. We're going to sit down and I'm going to go find a nurse because here is safe. But if you never ask, patients usually won't volunteer. Because if you tell somebody, hey, I need to take you for a little walk, they're going to try to cooperate. And they may not tell you, yeah, I'm not feeling right. They may just let you take them for a walk. So ask. Show that you care. Are you dizzy? They need to hear this for the test. They need to hear that. Are you dizzy? Or are you feeling okay? We talked about this. Patients have to know the chair is behind them before you sit them down. We've talked about that. And we use proper body mechanics when we lift the patient. That's 1 foot in front, 1 foot beside, grabbing that gait belt, and their hands need to be on your shoulders. Do you see that here? If you don't put their hands on your shoulders or ask them to, we end up with a, how do I put this? It's a physics problem. You are pulling at their center of gravity. If their shoulders don't go with you, they trail behind. And now you've got a off balance dynamic. You can actually see that. Let me show you. All right, where is it? I know it's in here. Oh, page 61. There's a picture at the top of page 61. There you go. That you can see. This actually was, I took this as a screen grab off of a video that's on YouTube. When your patient's arms are down, do you see how the whole upper body is kind of trailing behind? And that can put the patient off balance. So their hands need to be just laying on your shoulder, not around your neck. You don't want them to grab, just laying on your shoulders, and that moves them as a unit. Okay. Questions on that? This is important. Remove any obstacles before you go for a walk. You don't want to leave a patient standing there while you have to move something. So for the test, you want to look around. Is there anything in your way? And spoiler alert, there will be. They are going to put something in your way, probably a table just like this, in your way. Your job is to recognize that it's there and move it before you walk the patient. Now, because of this, your care plan says 10 steps, but your evaluator is going to give you a destination. They're going to say, I want you to walk to that table and back. And they're going to put something in your path. That's why they give you a specific destination. So they're going to put something in your way. If you're walking the patient and you're trying to move something out of your way while you're walking the patient, your focus is no longer on the patient. That's a huge deficiency. Good. Questions?
When you're lifting them, your hands are behind, right?
Yep. So you want them on the side or toward the back, wherever you can, it depends on the size of the patient. I'm going to demonstrate all of this for you. I don't know why I have to tell you this, but gait belts go over the patient's clothes. Don't remove the patient's clothes to put a gait belt on. That has actually happened quite a bit lately in testing. So this was passed on to me. Gait belts go over clothing. And they go around your patient's waist, not yours. Now, you may carry a gait belt around your waist. It's just having a place to have it. You'll see a lot of CNAs with gait belts around their waist just because that's how they're carrying it. But when it comes to assisting patients, the gait belt goes around the patient's waist. So we're going to hold the gait belt around the back or the sides. We never lift from the front. We don't grab the front of the gait belt and lift the patient. That's going to, again, have that patient trailing backward. Their hands should be, oh, here it is. This is the picture I was looking for. Their hands should be on your shoulders so they move as a unit. That you can see here, this is not good body mechanics at all. We're going to let the patient lead. We will walk slightly behind into one side with an underhand grip around that gait belt. And we're going to ask them throughout the skill how they feel. When we help them sit, remember they let us know the chair is behind them. And then we use that gait belt to help them sit in that same body mechanics motion. 1 foot in front, 1 foot beside, bend at the knees. Don't pull the gait belt across the skin or across the clothing. And make sure your patient is seated properly with their hips against the back of the chair. So let me show you this skill. I'm going to borrow your gait belt. I need a volunteer. Thank you. Come on over. Are we following me?
Oh, follow you.
Yeah, follow me. Follow me? Okay. Yep, good. Okay. All right. So because I don't have a curtain yet, I'm going to simulate pulling the curtain. Just follow me verbally. Here we go. Good morning, Miss Jones. How are you?
Good.
Good. My name is Patty. I'm your CNA today. Do you feel like going for a little walk?
Sure.
Okay, I'm going to go close your curtain, wash my hands, get my supplies, and I'll be right back. So I would pull the curtain, go to the sink, and wash my hands. Now that I have clean hands, I'll get my supplies. All right, Miss Jones, I see you have shoes on. Do they fit well?
Yes.
And are your feet flat on the floor?
I don't know, actually.
Okay, can you scoot forward just a little bit for me? There we go. Okay, I would look around for any obstacles, and there are none, but for the test, there probably will be. So move any obstacles before you put the gait belt on the patient. All right, Ms. Jones, I'm going to put this around your waist. It's going to help me lift you to a standing position and provide a little stability as we walk, okay?
Okay.
So I'm just going to slide this around your back. We're going to put it through the first guard by the alligator teeth, and we're going to pull it so that it's snug. I'm going to check it with 4 fingers, and we'll lock it into the second guard. Okay. All right, Ms. Jones, I'm going to help you to stand. You're going to put your hands on my shoulders. I'm going to grab the back of the gait belt, and on the count of 3, we're going to stand up, and we'll make sure that you're not dizzy, okay?
Okay.
Can you bring your feet together a little bit for me? 1 foot in front, 1 foot beside. Go ahead and put your hands up here, and on the count of 3, we're going to stand. 1, 2, 3. Feel okay?
Yes.
Are you dizzy at all?
No.
Okay. So I'm going to let you lead at your pace. We're going to walk over there to that desk. Yep. And I'm going to hold that gait belt in an underhand grip and just walk at your pace.
I don't know how fast.
Yep. And we're going to turn around and we're going to go back to the chair. Again, I'm holding in that underhand grip. Okay, back at the chair. I need you to turn around and back up so the backs of your knees hit the chair. Can you feel it there?
Yes.
You're going to put your hands on my shoulders, and on the count of 3, I'm going to help you sit. 1, 2, 3. Very good. We'll remove the gait belt. Go ahead and lift your arms. Are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
Nothing.
Would you like a magazine before I go?
Nothing.
Okay, here's your call light. There you go. If you need anything at all, just let us know. I'm going to open the curtain. The environment is clean. I'll put my gait belt back. Wash my hands. I'll probably review that care plan one more time to make sure that I hit all the points on the care plan, make any corrections, and then tell the evaluator my skill is done. Thank you.
You're welcome. Thank you.
Any questions on that? No? Good? Okay. All right, we're now going to move on to the longest skill we do. If you turn in your skills books, page 126. Thank you. So on page 126, you'll see it's partial bed bath. And we use almost every single principle in this skill. So everything we've learned has led us to this skill. Good? All right, so we're going to read the care plan. We'll do our opening, evaluate if we need gloves. And since we're touching personal skin here, you'll see that in a minute, we will use gloves. We're going to use a barrier. Our patient's undressed, so we need a privacy blanket. Linen rules apply. We want our patient to remain in the middle of the bed. Washing rules, whatever we wash, we rinse. Whatever rinse, we dry. We check water, they check water. Basin cleaning, same way we clean everything else. And the closing. We know all of those things. We have seen all of those things. So what we need to learn is skill-specific steps. So if you look on page 127, down at the bottom, you can see all of the supplies, and there's a lot of supplies for this skill. A lot of supplies. You need to memorize them, guys. There's no way around it. Make your flashcards. But if you go up to the top of the page there, you can see the care plan. It says to give the resident a partial bed bath and back rub. So partial means there's specific areas they want us to wash. That means if it says partial, they've got to tell us what do they want us to wash. So the rest of this care plan is going to define partial. Remember, partial is going to be different for every single patient that you care for. That care plan has to tell you what it wants washed. So this care plan tells us to wash the resident's face, neck, chest, abdomen, back, and one arm and hand with soap and water. Provide a brief back rub with lotion. We're not massage therapists. We are not deep tissuing anything. That's not what this is. This is just to wake up the nerve endings, get circulation back in the area, make the patient feel a little better. That's all that is. Short back rub. Dress the resident in a clean gown after bathing. Patients lying on back in center of bed can roll as directed. Yay. But is unable to assist with bathing. So that gives us our specifics. Down here are your step-by-step instructions, but we can really kind of shorten this face to waist, front and back, one arm and hand. Okay, so we can kind of shorten this. Face to waist, front and back, one arm and hand. Now, why aren't we doing the other arm? Because the evaluators want to be at home in their pool. It's just like hand care and foot care. If they see you do it on one side, they don't need to see it on the other. Good? Okay. All right. We're always going to wash the face first. We don't want to use soap on the face. Soap gets into the eyes. It stings the eyes. It dries the skin. No soap on the face. We'll wash that face first. There is one thing that we do need to learn, though. This is the very last principle we have to cover. Everything from here on out is just going to rehash what we've already learned. This is the very last thing we have to learn. And to learn this, use Leaves' method on wet body openings. We have to talk a little bit about the washing process again. Remember that we don't add soap to our water because we need it for rinsing. We use a paper towel to turn the water on. It should feel warm, not hot, not cold, just warm. And the patient has to check it too. We know all this. We're going to change that water if it gets cold or soapy, and whatever we wash, we rinse. Whatever we rinse, we dry. Everybody good with that so far? But here's the issue. This works as long as the skin is intact. If I'm just washing the hand and the skin is intact, this is exactly how I'm going to do it. This gets changed a little bit when we're washing wet body openings. Remember we talked about that whole chain of infection thing? Wet body openings. If we're going to wash wet body openings and rinse wet body openings, we have to have a way of doing it where we prevent cross-contamination. And that's what the Leaves method is going to teach us how to do. So I'm going to go over the Leaves method in just a minute. We change water if it's cold or soapy. Don't get your surfaces wet, and warm lotion up before we put it on, wipe off the excess. But this is what we're going to concentrate on now. Can I get all of, actually, can you pass them out?
Pass them out.
Mm-hmm. Okay. We learned this when we learned infection control, the chain of infection. We learned this. A wet body opening is any area that can let pathogens out or in. So the eyes, the nose, the mouth, genitals, rectal area, wounds, rashes, sores, and incisions. These are all wet body openings. And if we're going to wash any of these areas, we want to keep from bringing pathogens to them, and we want to keep from taking pathogens away from them into somewhere else. So when we're washing any wet body openings, we're going to use this Leaves method. Now, the way the leaf method works is this is just a plain old washcloth. You all have one of these now. It's a square. If you fold that square in half and then fold that in half, you end up with a smaller square. And we probably have these in our linen closet at home somewhere. But instead of looking at it as a square, I want you to look at it as a diamond. So just a quarter turn. And if we hold it as a diamond with the free edges at the top, the free ends at the top, not the folded corners, the free edges at the top, we're going to tuck one side in against our pinky, the other side in against our thumb, and we're going to hold it like this. When we hold it like this, we can wipe something, clean it, fold that over, and it traps the contamination underneath. Now we've got a clean surface that we can wipe something else and fold that over, and that traps the contamination underneath. Now we've got a new cleaning surface. So we can clean something, fold that over. We can clean something and fold that over. And if we need to, we even have the back side we can use to clean something. So anytime we're washing the eyes, nose, mouth, well, wait a minute. Partial bed bath has us cleaning the face, the eyes, the nose, and the mouth. So that means that we are going to use this Leaves method when we're washing the face. We don't need it when we're washing intact skin. So the rest of the body, the neck, the chest, the abdomen, the armpit, we don't need this leaves method. It's just a washcloth. But if we're going to wash the eyes, we do. If we're going to wash the nose, we do. Make sense?
You would flip it over when you were going from like the eyes, then flip it, and then to the nose, and then flip it.
Right. So one eye, I'm going to show you.
Okay.
Yeah, I'm going to show you. So we have the first leaf that we wipe something with and fold that over. The second leaf we wipe something with and fold that over. The third leaf we wipe something with and fold that over. And the fourth leaf we wipe something with and fold that over. And you can even use the back side if you need to. Everybody okay with that? Okay. So when you're holding it, the key here is to hold it so the free edges are at the top.
Okay.
And are you right-handed?
Yes.
So we're going to put it in your hand as a diamond. See how it's a diamond shape?
Yes.
We're going to close your thumb. We're going to tuck this in. And now you're going to wipe something like your eye. So wipe inner to outer corner. And then you'll fold that over. And then you wipe your other eye, inner to outer corner, and we're going to fold that over. And then you'd wipe the rest of your face, and then we'll fold that over, and we'll wipe the nose last.
Okay. Okay. Thank you.
You're welcome. Make sense? All right. So again, let's read that care plan, because this care plan is long, complex. So during the test, if you have to stop and go back and look at that care plan in the middle of the skill, you're allowed to. If you can't remember, wait a minute, am I supposed to wash both arms? Stop and go look at the care plan. Now, if you touch the care plan, you need to go wash your hands and re-glove. But you can look at it without touching it. All of you have these in your kits. These are the testing care plans. Testing care plans. So if you look at I'm not sure which number it is. Number 10. If you look at number 10, that is this. It's a word for word, exactly what's on here. So when you guys are practicing, these are the testing care plan sets. This is exactly the words you would get. So it tells us to give the resident a partial bed, bath, and back rub. Wash the resident's face, neck, chest, abdomen, one arm and hand, back. You don't have the care plan or the, oh.
Flashcard set?
Yeah, or the care plan set. That's what, yeah, we got it.
My apologies.
Okay, so wash the resident's face, neck, chest, abdomen, back, one arm and hand with soap and water. Provide a brief back rub with lotion. Guys, all we're going to do is get a little lotion in our hands, rub it together, start at the bottom of the back, go up in small circles to the shoulders, and we'll do that 3 times. 2 and 3. That's it. That's a brief back rub. Do you guys remember when you were little and you got sick and mom came along, just kind of rubbed your back a little bit and always made you feel better? That's what we're doing here. So we'll wash the face first. No soap on the face because it stings the eyes and it dries the skin. So water only. So we'll use the washcloth, holding it in that leaves method, and we're going to wipe inner to outer corner. Inner to outer corner. Wring that washcloth out thoroughly. No drippy, wet washcloth. So wring it out thoroughly. After you wring it out thoroughly, oops, you're going to go inner to outer corner. We'll fold that over. Inner to outer corner. Fold that over. Face. All this skin is intact. This is fine. Skin is intact. Fold that over. And when you get to the nose, different leaf because we don't want to let anything in the nose. Okay. Now, we didn't use soap, so once we wash the face with water, we're just going to dry it. Then we're going to move on to the rest of the body. There's no open skin here, none, no open skin. So just take your washcloth like you would anything else, put some soap on it, and wash quickly. You don't have to take a lot of time here. You want to be gentle, though. You don't want to like, you want to be gentle when you're cleaning, but clean quickly. Because remember, your patient is uncovered. They're cold. They're now wet. So let's move this along. Don't take forever. Good. But whatever we wash, we rinse. And whatever we rinse, we dry. Okay. Anytime we lift an arm, we always support it from below with a flat palm. Don't lift it from above. When we're done with the washcloths, we always set them on the barrier. Don't throw them on the floor. Don't put them back in the basin because we need to keep that water clean. The only exception to that is a rinsing washcloth. Remember, whatever we wash, we rinse. So if we used a washcloth to wash something and then we used a washcloth to rinse an area, we can put that rinsed washcloth back in the basin and use it again because we didn't apply soap directly to it. Rinsing washcloths can be reused. So you'll see on the supplies for this that you can do this whole skill with 5 washcloths. That means we're going to reuse the front rinsing washcloth. I'm sorry, 4 washcloths. It's going to tell you. You can do it with 4. Ideally, if you've got enough supplies, use 5. That way you don't have to reuse any washcloths. The reason that I show you how to do this is because most of the time in most settings, you're not going to have enough supplies to do everything you need to do. It's unfortunate, but you've got to learn how to do a lot with a little. So remember that you can reuse rinsing washcloths. You can't reuse anything you apply soap to, though. Good? All right, so once we get the front washed, rinsed, and dried, we're going to change the gown, turn the patient on their side, and then wash, rinse, and dry the back. That's the easy part. Wash, rinse, dry the back, just whatever's there. We'll give them a brief back rub for circulation and comfort. Warm that lotion up first, and then we wipe off the excess. And then we can tie that gown. Now, you can wait until you're all done, turn the patient back on their back, change the gown out, put them back on their side, and tie that gown. That's a whole lot of back and forth for that patient. And remember, they might have some energy issues. So it is best to change the gown before you roll them over to wash their back. Then, when you're all done, just tie the gown. Make sense? So just to review, we're going to get a barrier, get our supplies. We're going to get water using a paper towel. We'll protect the sheets with a towel during bathing. We're going to use a privacy blanket because they're undressed. We're going to use gloves because we're touching body openings and personal skin. First thing your gloves should touch is the patient. I knew I had this slide somewhere. Okay, so this is the once we're cleaning, inner to outer corner here on this eye. We'll fold that leaf over. And then inner to outer corner on this eye, fold that leaf over. And then the rest of the face and the nose last. We'll dry all of that area. And then we're going to wash the front of the body, rinse the front of the body, and dry the front of the body. Nobody cares how you do it. Nobody cares. I do the armpit last because ick. But nobody cares. Once you get the body washed, rinsed, and dried, change that gown, turn them over by scooting them towards you and rolling them away, and then wash, rinse, dry the back. Warm up your lotion, give them a little back rub, wipe off the excess, and tie the gown. Now, this is where everybody goes off the tracks, right? You can get this far. This is good. We're all fine with this. But this is the part that everybody's gets all confused. We now have a clean patient in a clean gown in the middle of the bed covered in a privacy blanket. We're good. You're going to want to take that blanket off. You have soiled gloves on. You need those gloves to put all of your soiled stuff away. So you need to stop. Your patient is fine. They're in the middle of the bed. Everybody wants to button the patient up. Finish this part. Not yet. You got to take care of your stuff first. You have to put your linens in the hamper. You've got to clean your basin and put it back in the drawer. You've got to get rid of your barrier and then take your gloves off. Then you can go back and get your patient buttoned up. But this is the part right here where most students struggle. This is when you start going, wait, what's my next step? I don't remember. What do I do now? You got to leave your patient not buttoned up yet. Take care of everything else, then go back and remove the privacy blanket by pulling up the sheet and doing your closing. So we'll put our soiled linens away. We'll clean our basin. We'll remove our gloves, and then we'll do our closing. Good? This is a long skill. Long skill. They give somebody with your level of experience 19 minutes to do this skill. 19 minutes. But the good news is, if you get this one, you get 2 super short skills to go with it. That's not horrible. All right, so let me show you this skill. We're doing good on time. Good. What's that?
Are you skipping the Ambulate video?
Yeah, because I demonstrated it live.
Gotcha.
Yep.
So partial bed bath then?
Yep, partial bed bath. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Good. I need to do partial bed bath. Is that okay? I'm going to close your curtain. Let me wash my hands, get my supplies, and I'll be right back. For this skill, I'm going to need a barrier for the table. This will give me a clean place to put my clean supplies. For this skill, I will need 4 washcloths, 2 towels, a clean gown, and a privacy blanket. It's a washing skill, so I will also need a basin, soap, and lotion. And I'll need a set of gloves. Miss Jones, let me go get some water. I'll be right back. Miss Jones, is this water appropriate temperature? Okay. And now I'm going to spread the privacy blanket out over you. This will help keep you warm and protect your privacy while we do this skill. I'm going to spread the blanket without snapping or shaking the blanket. And I'm going to pull your sheet down to about your waist. Okay, Miss Jones, I'm going to ask you to sit forward for me in just a moment so I can untie your gown. And I'm going to spread this towel out underneath you to keep your sheets dry while we bathe you. Can I assist you to sit up, please? Thank you. I'm going to untie your gown and spread the towel out on the bed. Go ahead and lay back down, Miss Jones. Thank you very much. And now I'm going to spread the towel out underneath the arm. I'll remove the gown on the side closest to me, supporting the elbow as I lift it. And I'm going to relocate the gown to the other side of the patient. This leaves the patient uncovered underneath the privacy blanket for bathing. The blanket will keep you warm. Now I can apply my gloves. I'll take the first washcloth and wring it out. And I'm going to use 4 corners. We'll wash the face first, no soap on the face. Ms. Jones, I'm going to wash your eyes. I'll start with the closest eye to me. I'm going to wash from the inner to outer corner. Very gently. And then we'll fold this sleeve over to prevent contamination from spreading to the other eye. Ms. Jones, I'm going to wash your other eye now, inner to outer corner. We'll fold that leaf over, and then I'm going to wash the remainder of the face. Using very gentle strokes and keeping control over the washcloth. We'll fold that leaf over and use the final washcloth for the nose. And then we'll set that aside. I'm going to take the towel and pat dry all areas of her face, making sure not to use too much force. We'll set the towel aside. We're going to take the second washcloth and wring it out. And we'll apply soap to the top leaf. We do not need to use the leaves method because all of her skin from this point is intact. We're going to wash behind the ear, under the chin, across the neck, the upper torso. We're going to lift the blanket to protect privacy but keep the patient covered while we wash down to the abdomen and up the side. Now for the exam, you are going to make sure the patient remains covered until the evaluators ask you to remove the blanket. At that point, you will just continue on. I am going to repeat these actions so that you can see what I have done. I'll remove the blanket for better visualization. Behind the ears, across the chin, the neck, the upper torso, around the breasts, down the abdomen, and up the side. Then we'll clean down the front of the arm, the hand, up the back of the arm, lifting at the elbow, and the armpit last. We'll set this washcloth aside because it has soap on it. We'll take the third washcloth in the basin and wring it out. And we're going to rinse all the areas that we just washed. So behind the ear, under the chin, across the neck, the upper torso, around the breasts, the abdomen, up the side, down the front of the arm, keeping the elbow supported on the bed. We'll rinse the hand, the back of the arm, and the armpit while supporting the arm. The rinse washcloth can go back in the basin for later use. Now we're going to dry all of those areas. So we're going to pat dry or use short, soft strokes, but nothing vigorous. Go ahead and lift your arm, Miss Jones. We'll set the towel aside. Now the patient has a clean torso, so we'll place the clean gown on her. Ms. Jones, can you reach your arm through here? I'll help you put your gown on. We'll lift the arm at the elbow, supporting it as we lift. And we'll spread the gown out. Okay, Ms. Jones, I'm going to go around to the other side of the bed now, and we'll dress the other arm. Since the care plan said that we only needed to wash one arm, we do not need to cleanse this other arm. That's per the care plan, but we do need to dress it. So I'll remove the soiled gown, and we're going to place this in dirty linen. And then I'll put the new gown on. Ms. Jones, can you reach through this armhole? Thank you. And go ahead and lift. Thank you. Okay, Ms. Jones, I'm going to ask you to turn onto your left side now. This is going to allow me to wash your back and give you a brief back rub. So I'm going to ask you to scoot toward me, and we're going to roll you onto your left side. Ready? Go ahead and scoot toward me. 1, 2, 3. Now the evaluator will hold the mannequin in place while you complete your cleaning. So I'm going to take the third washcloth, wring it out, and we'll soap the top leaf. I'm going to wash the back of the neck, the shoulders, and the back down to the waist. We'll set that washcloth aside. We'll take the final washcloth and wring it out, and we're going to rinse all of those areas. The back of the neck, the shoulders, and the back down to the waist. And then finally we'll dry all of those areas. The back of the neck and the shoulders, the back down to the waist. Now our care plan asks us to give the patient a brief back rub. So we're going to use a little bit of lotion, making sure to warm the lotion in our hands before we give them a back rub. Ms. Jones, I'm going to give you a little back rub now. I'm going to start at the small of your back and work my way up in small circles to your shoulders. We'll do this 3 times. This is for circulation purposes. 1, 2, one more, and 3. I'm going to wipe off the excess lotion. Now I can tie the patient's gown. And remove the towel that's protecting the linens. Ms. Jones, come on back onto your back, please, and scoot to the middle of the bed. Thank you. I do not want to touch that sheet that's going to go right up next to her face with soiled gloves, but I need my soiled gloves to take care of all of my dirty linens. Ms. Jones, I'll be right back. These items are going to go into dirty linen. Now I'm going to go clean the basin. I'll empty the basin and rinse it, and then pick it up with a paper towel. I'll dry the inside with one paper towel and throw it away, and then dry the outside with a paper towel and throw that away. And I'll get one for the drawer. I'll collect the soap and the lotion, placing them in the basin, and return the basin to its drawer for storage. Paper towels can be thrown away. This barrier is going to be discarded, and now I can remove my gloves. Okay, Ms. Jones, I'm going to remove your privacy blanket now and pull your sheet back up. Are you comfortable? Good. We're going to roll the privacy blanket in a ball so that the trailing edges don't contaminate other surfaces. This will be placed in dirty linen. Okay, Ms. Jones, is there anything else I can get for you while I'm here, such as a magazine? No? Okay, here's your call light. If you should need anything at all, please let me know.
I'm going to open the privacy curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done.
Okay. So we did have a question that came in. You didn't check the patient's name. So for the exam, we're not going to have ID bands to check. How are we going to identify our patient? By name, right? We're just going to announce their name. Correct. All right. Any other questions? No? All right. So today is the first day that we've got some practice time, and the vet just got here. So I'll be unpacking that in just a few minutes. But you do have one chapter of homework tonight, chapter 7. So you'll read chapter 7, and then you'll take the test on page 187 in your book. Would you like to pass out the class 5 review sheets? Yes, yeah, just leave them on the end of your table for me. So Jake's going to give you your review sheets for tonight. Remember, if you fill these out after each class, it makes a great review packet while you're preparing to test. Everything that you need to know about the test is on these review sheets. Those of you that are attending virtually, remember that you have access to these review sheets on flcnatraining.com as well. All right. That will wrap up today's lesson. The rest of the class is practice. You are not required to stay for practice. It's adult education. I can't hold you here. So you are welcome to leave if you need to. But if you stay, then I can help you identify your own strengths and weaknesses as you're practicing. And I am available for questions as well. Other than that, I will see you guys on Wednesday at 9 a.m. And on Wednesday, we'll have about an hour of practice at the end of the class. The following Monday, we'll have about an hour and a half. So as we go through the program, you get more and more practice time as we go. All right. So those of you that are joining virtually, thank you so much for tuning in. We will see you tomorrow for the game show at 11 a.m. on our YouTube channel. We'll be back here on Wednesday at 9 a.m. for class. Till next time, happy caregiving. Bye.